a remark, what Dr. Mahankal was telling. We also, when we, as a part of the phase 3 trial, when remifentanil, we were experiencing more bradycardia. Now it is available in the institute that the bradycardia is very intense with that, and post-operatively, unless we supplement some kind of opioid, patient will be very uncomfortable and they all with pain, with what Dr. Mahakali was talking about. Yeah.
I think I'm reminded of the time when the senior members in the audience used to see patients waking up hours later. So now it's quite the opposite. They wake up even before you take them out of the operating room. And as Subramaniam said rightly, it may be an advantage or a disadvantage. Right? So we do want in some instances patients to wake up slowly and don't want them to be too agitated. And I think in those situations, both the REMI drugs may not be very useful.
Sir, true, sir. I agree to an extent, and other perspective as well. One is we had long-acting ones, which we needed to use at a very high dosage because we wanted to cover the peak amount of stimulus. But that interferes with the awakening. What we have is a drug which can accommodate for any amount of stimulus when it is needed, and cover it up only with the post-operative. So the post-operative pain is much less than intraoperative pain. When intraoperative pain is maximum, use the drug which has the peak effect, and that effect is gone. Use something which is relevant for post-op. That is what it gives us an opportunity.
Yeah, with the remifentanil, I agree patient might have pain in the post-operative period, but as Dr. Subramanian was rightly telling, the change in attitude, like in the sense, understanding the pharmacology of drug and giving morphine in case we are not planning for any regional techniques, as in case of neurosurgical procedures, etc. If we time the morphine and give appropriate doses, it neither comes in the way of recovery, and at the same time, it provides a very good continuum of analgesia in the post-operative period, and use of multimodal analgesia probably.
Sir, I will ask you a question, sir. Sir, how frequent are you using airway ultrasound, sir?
I started using particularly for, not regularly, if I feel any interesting case is there. Otherwise, on a routine basis, on all the patient which enters in the OT, we're not using. But in ENT cases, particularly when they talk about these, any vocal cord movement, any problem, definitely I'm using it.
I think with reference, Subramanian, after you. Your comment after what he said, yeah. You have something to say? You move to the mic.
Thank you, sir.
Okay. I also want to congratulate Dr. Balasubramanian. It was a very difficult topic. I think nowadays, as patients are getting older, they are, we are diagnosing, the physicians are diagnosing more conditions. They're putting them on very complicated drugs. We can't even pronounce their names. I know how you took us through that beautiful lecture, pronouncing all the names so beautifully. And I think drug companies must learn to give better names to medications. We can't even pronounce them. But it's very important because it's a practical issue now. Before we take up a patient for surgery, we have to be very, very careful on what kind of medications they are on. They're very likely to be on long-acting medications that will have anesthetic implications. So that's becoming more and more complicated. Another field which you're not covering in this particular session is the psychiatric medications. A lot of people are now on antipsychotic medications, and I think that also needs to be kept in mind as an interaction between pharmacology and our anesthesia. Of course, light at the end of the tunnel. Thank you for using my suggestion. No questions from the audience. How many have used remifentanil? Please raise your hand. There's only one person. No, other than you, there's only one person in the audience. Okay. So would you like to share any experiences of yours? We'll get a mic over to you.
You give there, the third row. Come.
Hi, Ramesh. Good to see you after a long time. Yeah. You must have used it in Brunei, I guess, huh?
Yeah, I have used remifentanil for most of the time. We use it for neuromonitoring, and when there is a muscle relaxant is not required during the surgery. So like a parotid surgery or thyroid surgery, sometimes they have doubt about the nerve, and the nerve preservation surgery or scoliosis surgery like that. But what I observed is when you use remifentanil, there is a especially little higher dose like in TCI more than 4 nanogram per ml target, we see the chest rigidity is a major issue. So quite a significant number of patients will get chest rigidity, and it will become very difficult to ventilate the patient so bad, so that we have to give the relaxant, muscle relaxant, to break the chest rigidity. So that is one main disadvantage. And as Dr. Ravindra told, towards the end of surgery, we have to time it to give the long-acting relaxant. Also, when you use the propofol, TCI, and remifentanil, the hypotension is another issue. So, what we used to do is combine with the small dose of this noradrenaline, like we used to dilute 4 milligram in 150 ml of saline and start with 1 to 2 ml per hour to overcome this hypotensive effect of remifentanil and propofol. Otherwise, it is a wonderful drug, but we have to choose the patient, what I feel. And another disadvantage is the cost. So, cost benefit analysis, we cannot use it for all patients. So, when there is a scoliosis surgery where there is required intra-op monitoring, or sometimes surgeon have a doubt about the spinal cord status, so awakening is required, then remifentanil and propofol combination works beautifully. Thank you.
Thank you, Ramesh, for your experiential inputs. Thank you. So, Subramanian, do you, so remifentanil was not in the market when I was practicing. Would it be a good drug to use for awake craniotomies?
Sir, it will be a wonderful drug to use for awake craniotomies, because you can, especially when you use it as a TCI, a target controlled infusion, you are never giving a big bolus, and you can start, instead of start from 1, you can start from 0.5. The patient is in fully contact with you, never loses touch with what is there. And at the time when it is required, you can give adequate, because once you give a scalp block, very few stimulus is there. When the stimulus is there, you can increase it slightly, and patient is still in touch with us. He's not completely knocked off. That's what I feel.
Yeah, this is what they call the awake asleep anesthesia. I think these drugs are all going to make jobs like that very simple. Yeah.
And the cost, because sir mentioned about the cost of 1 milligram ampule in India currently is 900 rupees, 2 milligram is 1,200 rupees. If you look at the cost of IV propofol, it's 650 rupees. Per day, it costs 2,500 rupees. This costs half of it if you look in terms of cost. Availability is an issue. So one of the things which Madam just highlighted is the drug controller has approved it. The excise department is in the process of allowing for transfer. So anyone who is renewing, they are getting it. Addition has been a difficult one, but if you're getting a fresh approval, you will get it. That is what is the current government regulations.
Yes, doctor, please.
So I'm a third-year resident in Ramachandra. We use remifentanil on a regular basis. Especially, I'm doing a study with remifentanil and rocuronium and sugammadex. So the main purpose was that I wanted to see what was the actual dose of sugammadex required to reverse the rocuronium based on TOF monitoring. So during that, we found in the initial pilot studies that the patients, we couldn't, for my parent article, we were giving sugammadex, waiting for 5 minutes to see how much was the TOF increasing. And then based on our subjective, if patient can be extubated or not, we were extubating. But that time patient had lot of, used to buck and a lot of hemodynamic changes. So that is why we started remifentanil TCI pre-induction and continued it throughout the extubation. So as sir told, before induction, we start remifentanil until it reaches a target of between 2 to 4 before we give propofol and all. So that time only there is a lot of bradycardia and hypotension. So for cardiac patients, we are very wary of using it because we have seen profound hypotension and which is and before extubation, we'll stop Remi and around 10 to 15 minutes, we'll give fentanyl 0.5 mics per kg bolus dose for post-operative pain control along with your other NSAIDs and paracetamol. So that is my experience.
Sorry, I just want to add a lot of mention about bradycardia. So controlled bradycardia is different from bradycardia happening, which causes hypotension. So here, when we use remifentanil, the heart rate is a surrogate marker to ensure that you are giving adequate dose or overdosing it. So we have a tendency to target 4 to 6 every time, and not required. Even 1 to 2 is good enough. And if you use heart rate as a surrogate marker, you will never overdose. So titrate according to the stimulus. That is the rule of thumb which we all, I think, should draw.
So I think 2
Yeah.
nanogram per ml is, like I've seen, that is stable for everyone. Thanks.
We have time for one more question. We need to wind up the session. After that, yes,
I have one
Anand, yes.
Yeah, this question is to Anil. Actually, I discussed this particular point regarding use of ultrasound for prediction of difficult airway. The general teaching was if the larynx is more anterior, that means it is difficult airway. But now there is more of importance for skin to epiglottis distance measurement. If the distance is more, it predicts difficult airway. Even now I fail to understand. Anil told me that it is the maneuverability, but still if you can explain this more, how exactly. I was thinking if the distance is lesser, that means it should predict difficult airway.
Sir, the fat deposition occurs usually circumferentially. It will never occur only in a particular area. Suppose if there is more fat tissue deposition between the epiglottis and the thyroid membrane, which generally will not. Everywhere there will not be no fat deposition or very light. When the thickness increases, it is mostly fatty tissue. When it is occurring there, it is also occurs circumferentially around the whole airway tissues. That means in those particular patients, the thick neck circumference, if you observe, that will also be more. So cumulatively, everything will adds up to the difficulty in laryngoscopy and visualization of the glottis. That's how it is taken. There are further studies required, but the specificity and sensitivity and positive predictive value of this alone is not great. It is somewhere between 30 to 40% yet.
Hello, I'm Ravi Raj from New Zealand. So I use Remi all the time, almost. TCA is very common now. Inhalation is going off. Sorry? Remi. Remifentanil, yeah. So I'm using Remi and propofol TCI without relaxant for most of the ENT cases that needs nerve monitoring. So basically use a MAD device to get a intratracheal lidocaine and just intubate. So I don't touch muscle relaxant at all. These cases, usually they don't need a lot of analgesia, but still you need to give, whenever you're using Remi is mainly the propofol sparing effect. It is not I won't consider as an analgesic there. So I will give a routine dose. For example, if the procedure is painful, there is no block done, then I'll be giving my routine fentanyl and morphine, everything. But if there is a regional block, or if the ENT surgeon is going to do a lot of local and things, then you don't need any morphine or long-acting. So these patients wake up very easy and they will move from, I work around a single goal. Most of these patients can wake up and move from the operating table to the bed on their own at the end of the surgery. That is achievable. Thank you.
Thank you for raising a good point. When you use Remi at appropriate doses, it is anesthetic sparing, that is, you can reduce the anesthetic, and muscle relaxant reducing as well. Two important things it does. Both of you have highlighted. And I also just want people to exhort. I'm sure all of you have observed, after giving a spinal, after 10-15 minutes, the patient goes to sleep because there is no pain. Here again, the pain is taken care of by remifentanil. Automatically, the patient goes to sleep and dosage reduces. That's what I think is happening.
Thank you.
Ravi and me were
I need to interrupt you, sorry. I need to go to the next hall. I have a lecture there. Thank you, everybody.
Ravi and me were co-residents in Toronto, and we saw the post-FRCA, the British guys used to have a small little bag of Remi in their pocket. So they used to dilute 2 milligrams of Remi in 100 ml normal saline, and they used to carry it around every day. So this used to be their practice. And they used to use it for cough during extubation. So any patient has cough during extubation, just give a small little bolus of Remi. It abates the cough and prevents hemodynamic changes during extubation. So that was one indication which we were hesitant to use, but they were very liberal in doing so.
Thank you everyone for the wonderful talks and the discussion that followed. Thank you.
We now request our chairpersons to kindly present mementos to our distinguished speakers. We request Dr. Ravindra sir to present mementos to Dr. Subramanya Mahankali. We request Dr. Sudhir Hegde sir to present mementos to Dr. Balasubramanya H. We request Dr. Ravindra sir to present mementos to Dr. Sumalata Arshetty. We request Dr. Sudhir Hegde sir to present memento to Dr. Anil Kumar H.